Hello, everyone. We will be talking about the advances made regarding finding a cure for HIV, which is hopefully the next frontier in HIV care. So nowadays, we mostly talk about pre-exposure prophylaxis with all the promising trials and studies regarding being able to prevent HIV transmission by taking either tenofovir or a combination of tenofovir and emtricitabine. Unfortunately, for about 33 million patients worldwide, it's already too late for PrEP because this is the number of patients living with HIV worldwide. Looking at the U.S. demographics of new incidents of HIV, we see that it does affect all races. 44% new cases of HIV are in the Afro-American population, 32% of all new cases are in the white population, 20% in the Hispanic Latino population. So it does really affect all the major groups in the U.S. The even more concerning is actually the HIV incidence by age at infection. So this is the incidence by age in 2009, and we see that unfortunately all the new cases are mostly in the quite young, so ages 13 to 29, adolescents, pre-adolescents, and young teenagers. And then the next big piece of the pie chart is the 30 to 39 age group. So this really shows us that we have a population who will need to live with this disease for hopefully another 60 or 70 years, or entirely essentially the majority of their lifetime. So that highlights the importance of being able to find a cure to this lifelong incurable disease as of now. So far, as of 3-4 years ago, this was thought to be basically a mission impossible up until February 2008, where a patient in Germany by the name of Timothy Brown, and referred to as the Berlin patient, was actually cured from HIV after receiving a stem cell transplant. So the way this transpired is that he was a known HIV patient. Risk factor was MSM. He basically was diagnosed with AML and underwent through the usual chemotherapy, and then in February of 2008 over here had his first stem cell transplant. Now for him, they chose to give him a stem cell transplant from a CCR5 delta 32 homozygous patient. So this is the kind of patients who are inherently resistant to acquiring or being infected with HIV because they have a mutation in the CCR5 receptor, which is the receptor needed for HIV to enter into the CD4 T cells and cause the lifelong infection. So they actually gave him stem cell transplant from a patient who has this mutation. The patient our Berlin patient achieved 100% chimerism, and then went on to actually have a second relapse after the initial stem cell transplant and required a second stem cell transplant, which achieved again 100% chimerism. And as of now, he has remained HIV-free after 4.5 years of follow-up, and studies have been done looking at his gut mucosa, and they were able to show that the gut mucosa was also replenished with CD4 T cells, and that all the host T cells have been actually replaced with the transplant T cells. So this was basically a proof of concept that cure of HIV is potentially attainable, although doing a stem cell transplant on everyone is obviously not a realistic approach. So what is a realistic approach? So what needs to be achieved in order to potentially cure HIV is, number one, we need to stop viral replication. We need to be able to identify all the reservoirs in which non-replicating virus persists. We need to eliminate these reservoirs once we've identified them. We need to make the cells resistant to HIV infection, and we also need to be able to enhance the host HIV-specific immune responses. Now, we know that even in patients who are doing very well on HAART or combined antiretroviral treatment and who are suppressed to below 50 viral load or 50 copies per ml, which is the limit of detection of the current assays used, we know that there is a persistent low-level viremia which can be detected with the single copy assay. So the genetic analysis, though, of this residual viremia, which is, again, 1 to 5 copies per ml usually, is challenging because of the extremely low amount of template viral RNA in the plasma of patients suppressed on HAART. However, the concern is, well, is this residual viremia representative of ongoing viral replication in the face of highly active antiretroviral therapy? And the answer is most likely no, and we have two strong proofs to validate this theory. Number one is this residual viremia lacks any drug resistance even in patients who have been on HAART for years, and even when the regimens actually include drugs with very low genetic barriers to resistance. So essentially, studies have shown that this residual viremia has basically lacks any evolutionary change and is essentially archival in nature, which is not what you would expect if the virus was actively replicating in the face of antiretroviral therapy. If that were the case, you would expect actually that virus to start developing resistance, but all studies have shown that this residual viremia actually is all wild-type virus and has no resistance to the current antiretrovirals. Another proof that kind of reinforces the idea that this residual viremia is not because of ongoing viral replication in the face of antiretrovirals is that intensification trials, which basically means adding a fourth active antiretroviral agent to the already triple HAART regimen. So by adding a fourth antiretroviral to patients that are already suppressed to below viral copies per ml, it was not shown that there was any benefit with regards to greater viral suppression. So one was still able to detect this residual viremia despite a fourth antiretroviral. And intensification trials have really been done with many additional antiretrovirals, so be it ritonavir-boosted atazanavir or ritonavir-boosted lopinavir. They've tried efavirenz, maravira, craltegravir, and some have shown some benefits with decreasing the general immune activation associated with HIV, but again, no benefit with total suppression of the residual viremia. So this slide shows that the previously believed concept, which was, you start HAART up on top and then your viral slope goes down, but you still have ongoing replication, which explains why you are seeing this residual viremia. But because of the two proofs I previously mentioned, what is believed to now happen is once you start HAART over here with the arrow, you effectively block the great majority of ongoing viral replication, and the persistent low-level viremia, which is below the level of detection of the commercially used assay, is thought to be due to basically a release of virus from reservoirs, which brought upon the idea that there are these reservoirs where the virus is latent and is only released every so often. Another hint to the existence of reservoir came from looking at the viral dynamics, or basically what happens with the virus once you initiate HAART and what happens with the viral decay slopes. So as we see here with the initiation of therapy, we initially have a very rapid or very steep slope, a very rapid decay of the virus, and a very rapid decrease in the HIV viral load. And then this initial rapid decline is followed by a slower decline, so the slope is a bit less steep, and then a third phase, which is actually a plateau, a very low level of viremia, which you only get an insight about when you have those blips, which are typically you see in a totally suppressed HIV patient with a viral level of below 50, but that every now and then you might see a blip, which is usually a resurgence of HIV viremia, but usually it is below 500 copies. So this gave us a hint that there might be more than one reservoir. And so this is what is believed to happen with the initial HIV infection. We see the HIV virion attacking and entering the CD4 T cells using the receptor we previously mentioned, the CCR5 receptor, and basically entry of HIV and establishing infection into the T cells. And we see that very early on during the primary HIV infection, the virus disseminates throughout the body into the regional lymph nodes and hematogenously to basically establish reservoirs in the brain and in the GU tract and in the lymphoid tissues, the spleen, the gut-associated lymphoid tissue, and the lymph nodes. And to some extent, these reservoirs are believed to be what is called anatomic sanctuaries, such as the brain, such as the GU tract, whereby to some extent, the antiretroviral used might not be able to achieve a high enough level in these anatomical sites, such as in the brain or in the GU tract, where despite having your virus totally suppressed in the serum, one might still be able to detect a virus in the GU tract or in the brain, which is to some extent could be explained by the fact that the drug levels are not as high. Most of the cells in these reservoirs are basically resting memory T cells, and this is a schematic to show what happens to T cells. They are initially naive. They are exposed to an antigen which activates them, so they become activated T cells with effector functions that are able to proliferate and basically able to propagate the HIV infection, and to some extent are killed by HIV, but a few of them go on to become resting memory T cells, whereby they do incorporate the latent HIV provirus, so the HIV genome becomes incorporated within their genome, but they are resting and not actively replicating, but the virus remains archived in them. So now that we have somewhat identified some of those reservoirs, how do we go by eliminating these reservoirs in order to achieve and eradicate HIV? So the latent reservoir for HIV, as I said, is mostly resting T cells. The frequency of this reservoir is around 1 per million T cells. It is on the order of 10 to the power 5 to 10 to the power 6 cells, with a half-life of 44 months and basically time to eradicate of around 70 years with antiretroviral therapy. So basically not achievable within a person's lifetime. So what we need to do in order to purge this reservoir is be able to achieve activation or stimulation of this reservoir, so removing the T cells from their latency and allowing them to be stimulated so that they can be killed or purged. And we do not want to achieve general T cell activation as what can be done with interleukin-2, and the trials with interleukin-2 have not shown to give any clinical benefits. So what needs to be achieved is reactivating the latent virus without causing a generalized T cell activation. And the hypothesis is by reactivating the latent reservoir while keeping the patient on a highly active antiretroviral treatment, then these T cells are able to be killed either by the viral cytopathic effect or can be killed then by the host immune system. Now, SAHA, which is a sub-aryl lanolide hydroxamic acid, or otherwise known as vorinostat, is an agent that is known to be used and is already FDA approved for the treatment of cutaneous T-cell lymphoma. So it is known not to have any major side effects, at least on the short term. And it has been shown that it does reactivate HIV from latently infected cells by working via the phosphatidyl inositol 3 kinase pathway. By affecting this pathway, it leads to the release of a critical transcription cofactor for HIV, so then the cells become activated again, and thus it accelerates the decay of these latent reservoirs. During this past CROI, earlier this month, March of 2012, in Seattle, two abstracts were presented, one by Margolis, one by Lewin, and they showed that although SAHA does activate T cells in vitro, unfortunately there was no change in residual viremia with a single copy assay. So it seemed like just by activating the T cells, we do not achieve purging of the reservoirs. Another study presented earlier this month at CROI in Seattle by Liang Chan showed that elimination of the latent reservoir for HIV-1 requires induction of the CTR responsive or cytotoxic responses. So the hypothesis, as I previously went over, was that by activating the T cells or taking them out of their latency, the T cell or the reservoir that is now activated is hopefully now killed either by the CTR response or by the viral cytopathic effect. However, in the Liang Chan studies, that did not appear to be the case, and the only way they were able to achieve some killing of the now activated latent T cells is by inducing CD8 T cells, exposing them to the HIV antigen and activating them, and then mixing those CD8 effector T cells that are HIV specific with the now activated CD4 T cells. And this is how they were able to achieve some of the killing or purging of the reservoir. So we definitely need to do more to purge the reservoir than just to be able to activate the latent CD4 T cells. Another basically receptor identified is called PD-1 or programmed death. And as we know, the chronic immune activation in HIV patient is the one that leads to exhaustion and premature senescence of the immune system. And PD-1 expression on the T cells has been shown to correlate with T cell exhaustion and disease progression in HIV. And so Chaumont et al. And other studies have shown that PD-1 expression correlates with the reservoir size. So the more the percentage of PD-1 positive T cells, the higher the number of integrated HIV DNA copies within T cells, which is basically a marker of the reservoir. So the PD-1 and PD ligand pathway is an important pathway and potentially a target for future HIV therapies. So it is known that the PD-1 interacts with its two ligands called PD ligand 1 and PD ligand 2 to convey negative signals to T cells, so basically blocking them from proliferating. And so if we can block this negative pathway, then we can restore T cell function at least in vitro. And in HIV-infected patients, it has been shown that the PD-1 expression is directly correlated with the viral load. And it also has been shown that highly active antiretroviral therapy does downregulate the expression of PD-1 on CD4 and CD8 T cells. So this just goes to show that this is the PD-1 on the CD4 T cells. When it interacts with the PD ligand, it does suppress T cell activation. And so this is potentially a step that can be a target for future therapeutics if we can get an anti-PD-1 blocking antibody, so we can block this negative pathway and thus lead to activation of the latent CD4 T cell. So far, there are no human studies done with the PD-1 pathway. However, there are studies done in macaques, which are monkeys. And again, an abstract was presented earlier this month at CROI, where they used a PD-1 blockade in macaques infected with the SIV or the simian immunodeficiency virus, which is the equivalent of HIV virus in macaques, and they were able to show that a subset of those infected animals maintained a lower viral set point after PD-1 blockade, but not all of them. So they were interested in seeing what made that subset of animals so special, and they found that PD-1 blockade increased the total proliferating CD4 and CD8 T cells in all animals. However, in the controllers, or the subset of animals that did achieve a lower viral load after PD-1 blockade, this particular subset of animals had a higher level of SIV-specific CD8 T cells post-treatment interruption. So again, we see that we do need the CD8 T cells cytotoxic effect in order to achieve purging of the reservoir. And now there are plans for a phase 1 trials in humans using PD-1 blocking agents. Now, moving on, another strategy that can potentially lead to a cure is to make the cells resistant to HIV infection. That would at least achieve a functional cure by preventing additional CD4 T cells from being infected. So as I alluded earlier when I spoke about the Berlin patient and the stem cell transplant he received, so CCR5 is basically a needed receptor on the CD4 T cells, which HIV uses in order to enter and infect the CD4 T cells. And there is a subset of patients that have a delta 32 mutation in that particular receptor, which makes them immune to being infected with HIV, because the mutation basically blocks HIV from being able to use the CCR5 receptor for entry. And researchers have been able to basically use zinc finger nucleases, which act here as scissors, and insert the CCR5 mutated receptor, so delta 32 mutation, into a plasmid, into an adenovirus, and then the plan is with the mixing of this adenovirus with other CD4 T cells, you are able to insert the plasmid that you want containing the CCR5 delta 32. And so far, there has been trials done at UPenn and others where you can see where 6 patients who were totally suppressed with a viral load below 50 copies on heart, their CD4 T cells were basically obtained via plasmapheresis. They were mixed with T cells that include the CCR5 delta 32, and then you are able to expand the autologous R5 disrupted T cells, again meaning disrupted, meaning containing the delta 32 mutation, which makes them immune to HIV entry, and then you are able to reinfuse into the patient those expanded autologous disrupted R5 T cells. And then what they did is they stopped the HIV therapy. They stopped highly active antiretroviral therapy after infusion of the cells to see what happens. And follow-up 24 weeks later showed that the percent of CCR5 disruption achievable was on the order of 1 to 6% only. So the next 2 slides were presented by Dr. Pablo Tebas from UPenn earlier this month at CROI in Seattle. And basically, he combined 2 studies which used this strategy of inserting R5 defective CD4 T cells receptors. It's an open-label, single-dose studies. The study population is basically aviremic HIV subjects on highly active antiretroviral treatment. 6 of them are subsets which were called immune responders because on heart they were able to achieve CD4 count above 450 cells, and the immune non-responders were 15 patients who are actually suppressed, so aviremic or viral load below 50 copies on heart, but not able to have a robust immune response in the sense that the CD4 T cells remained below 500. And then they were able to infuse those mutated CD4 T cells, and then they followed the safety and tolerability, which was for the most part infusing these T cells were pretty much well tolerated. They looked at the change in CD4 counts and CD4 to CD8 ratio, the persistence and trafficking of these mutated cells, the change in HIV proviral DNA, which is a surrogate for the reservoir, and the change in HIV RNA during heart treatment interruption in the immune responders, which were the 6 patients over here. And as we can see, all these patients over here prior to the infusion had a viral load below 50 copies, and then after the infusion, their antiretroviral treatment was discontinued. And we see that for the most part, their viral load did somewhat go down, but was not suppressed until the dotted line when the antiretroviral therapy was initiated again. The red line here is the limit of detection. So if you can see here, this patient in green is actually the most interesting of the 6 patients because you can see that his viral load after the infusion and with the treatment interruption actually went all the way down to undetectable even before the dotted line where HIV treatment was reinitiated. And basically, this patient was found to be a delta 32 heterozygote himself. So he actually to start with was heterozygous to the mutation that allows that blocks HIV entry by using the CCR5 receptors. So moving forward, the plan, as discussed by Dr. Tebas and Croy, is to use this particular strategy of infusing CCR5 mutated CD4 T cells. It is going to be used moving forward in a subset of patients that are heterozygous to the Delta 32 mutation, because you would expect them after the end of infusion to have more than 6% of their T cells now carrying the CCR5 Delta 32. Other strategies that are being worked up now is how do we achieve a much bigger ratio of these T cells after the infusion that persist with the CCR5 Delta 32 mutation. So this is all going to be done in future studies. So I think by now we have gone through the fact that it doesn't seem likely that there will be only one intervention that will be curative for HIV. It seems more like we need to attack HIV from multiple different fronts. And because of that, there is this study called the IRAMUNE studies, IRAMUNE 2.0, which is being undertaken in the US, and IRAMUNE 01 in Europe. And this is basically looking at attacking HIV from different fronts, as I mentioned. So in Europe, control arm, or arm A, will be looking at patients that are already maintained on combined antiretroviral or highly active antiretroviral therapy and adding intensification with two agents, raltegravir and maraviroc. And this will be compared to the arm B, where you are keeping them on HAART, adding intensification and raltegravir and maraviroc, and then adding interleukin-7, which is a cytokine that allows the CD4 T cells to proliferate. Whereas in the U.S., this study is being undertaken in 3 centers in Chicago, San Francisco, and New York. And the arm A, again, as in Europe, combined antiretroviral with intensification with raltegravir and maraviroc. However, the intervention arm in the U.S., instead of adding interleukin-7, they will be adding HIV AD5, which is a therapeutic vaccine. So with the goal of enhancing the host HIV immune responses, and the results, which should be very interesting and hopefully promising, are supposed to be released next year, sometime in 2013. So challenges in HIV Cure trials are multiple. To name a few, you are actually relying on biomarkers, while the assumption that this biomarker is a surrogate for disease progression and influencing it will translate into clinical benefit, which has not been the case all the time, as in the interleukin-2 trials, where they were very promising in vitro. However, despite interleukin-2 being able to activate T cells, it did not translate into any clinical benefit. Another challenge is that the number of clinical events is already very small in HIV patients who are maintained on HAART and doing well with total viral suppression. So, you have to use these patients as your control arm, but already this control arm is healthy enough and doesn't have much clinical events. And the other, problematic issue inherent in HIV Cure trials is at some point you might need to stop their antiretrovirals to see if your new intervention is able to suppress their viral load while being off of HAART. And so that is problematic because, as we know now, the standard of care for all HIV patients is to remain on HAART, and we know that treatment interruptions are actually deleterious to the patient and have some negative consequences. So there is an ethical dilemma there. And of course, the potential risk and toxicities of any investigational drug in patients who are already healthy and stable and doing very well on HAART. So again, the dilemma if why would you want to potentially expose them to toxicities from an investigational drug that might not turn out to be beneficial? So far, we have one confirmed case of HIV Cure, 1 out of 33 million patients, that is. And we know that cure will require shrinking and eradicating the reservoir of HIV-infected latent CD4 T cells, but also we need to disrupt further and ongoing HIV infection within the host. There are many ongoing trials targeting the many different steps of disease progression and disease maintenance, and some of these trials are actually quite promising, but so far there is no basically magic cure, no silver bullet. Thank you very much for your attention.
Thank you very much for that stimulating presentation, Dr. Elbajani. As you saw there and heard, there was considerable amount of basic science involved as well as clinical practicality in the ongoing approach to find a cure for HIV. We do hope you found this interesting, educational, and enlightening. Please do not forget to complete your post-CME questions as well as other information requested so that you may obtain your CME credits. We thank you for listening in on this presentation and look forward to working with you in future presentations. Have a good day.